Across hospitals in the United States, there are incidents that were documented, reviewed, and then quietly left without resolution. Patients vanished between routine checks, medical records shifted without explanation, and staff accounts failed to align with official timelines. These cases remain buried in reports and internal systems, incomplete and unresolved. In this video, we'll break down 8 hospital incidents that still lack clear answers. The patient who spoke a different name. On the evening of March 14, 2012, a man later identified as Daniel Reeves was admitted to St. Mark's Regional Medical Center in Bowling Green, Kentucky, after being found disoriented near a highway rest area off Interstate 65. According to the initial incident report filed by responding deputies, the man appeared dehydrated, confused, and unable to explain how he had arrived at the location. He carried no wallet, no phone, and no form of identification. Paramedics transported him to the hospital at approximately 7:40 p.m., where intake staff assigned him a temporary identity pending verification. During triage, the man repeatedly stated his name was Michael Turner, speaking calmly but with clear insistence. Hospital staff noted no signs of intoxication or acute injury, though his vital signs suggested prolonged exposure to the elements. Fingerprints were taken as part of routine unidentified patient protocol and submitted to state databases. By early morning, a match was returned identifying him as Daniel Reeves, a 38-year-old resident of Elizabethtown, Kentucky, with no criminal record and no documented history of psychiatric illness. When staff informed him of the identification, he denied the name entirely and again stated without hesitation that he was Michael Turner. Nurses documented that he appeared neither agitated nor delusional in a conventional sense. His responses were consistent, his speech coherent, and he answered all other questions accurately, including current date, location, and basic general knowledge. Attempts to contact Reeves's listed next of kin led to his sister, Laura Reeves, who arrived at the hospital later that afternoon. According to her statement, she immediately recognized him as her brother, though she described his demeanor as unfamiliar and detached. When she addressed him as Daniel, he reportedly looked at her without recognition and corrected her, again using the name Michael Turner. Medical staff ordered a neurological evaluation, including imaging and cognitive testing. Results showed no evidence of head trauma, stroke, or neurological disorder that could account for identity confusion. A psychiatric consult was conducted the following day. The attending psychiatrist noted that while the patient demonstrated a fixed belief regarding his identity, he did not exhibit broader signs of psychosis, memory fragmentation, or dissociative episodes typically associated with identity disturbances. He retained detailed recall of events he claimed belonged to his life, including an address in Louisville, employment at a warehouse, and references to individuals whose names could not be verified in any accessible records. Investigators later attempted to trace the identity of Michael Turner using the details provided. No individual matching the description, employment history, or personal connections described by the patient could be located in Kentucky or surrounding states. Meanwhile, Daniel Reeves's documented life remained intact. Employment records showed he had worked as a maintenance technician at a manufacturing facility in Elizabethtown for over a decade. Coworkers described him as quiet but reliable. Security footage from his workplace showed him leaving at the end of his shift 2 days before he was found, with no indication of distress or unusual behavior. His vehicle was later discovered abandoned in a grocery store parking lot approximately 40 miles from where he was found. There were no signs of forced entry or struggle. Inside the car, investigators found his wallet, containing his driver's license and credit cards, all untouched. Surveillance footage from the parking lot showed the vehicle arriving late at night, but the camera angle did not clearly capture the driver's face. Hospital staff continued to monitor his condition over the next several days. Throughout his stay, the man consistently identified himself as Michael Turner. He complied with all medical instructions, engaged in conversation, and showed no cognitive impairment outside of the identity discrepancy. When presented with photographs from Daniel Reeves's life, including family gatherings and workplace images, he acknowledged the images but stated that the person depicted was not him. Staff documented that he did not express confusion about the situation, only disagreement. After 5 days with no medical justification for continued hospitalization, The question of discharge became a matter of administrative concern. Legally, he was Daniel Reeves. Medically, he was stable. Psychiatrically, he did not meet criteria for involuntary commitment. His sister declined to take responsibility for him unless he acknowledged his identity, citing concern for his behavior. Social services became involved, but without evidence of incapacity, options were limited. On March 20th, 2012, he was discharged. The discharge paperwork listed him as Daniel Reeves, which he refused to sign under that name. Instead, he signed Michael Turner in clear, consistent handwriting. According to hospital records, he left the facility alone at approximately 2:15 p.m. Security footage shows him exiting through the main entrance, pausing briefly outside as if orienting himself, and then walking out of frame toward the parking lot. There is no record of him arranging transportation. No confirmed sightings of him were reported after that point. In the weeks that followed, local authorities opened a missing persons case under the name Daniel Reeves. His bank accounts showed no activity. His phone remained inactive. No new identification was issued under either name. Investigators revisited the details he had provided about Michael Turner, expanding the search beyond state lines, but found no matching records in employment databases, property registries, or public records. The name existed in multiple instances across the country, but none aligned with the specific history he had described. The case gradually lost momentum. Without evidence of foul play and with the subject having left the hospital voluntarily, there were limited avenues for further investigation. His sister continued to advocate for answers, maintaining that while the man in the hospital had her brother's face, his behavior and responses suggested a complete disconnect from his prior life. Medical staff who interacted with him later stated in internal interviews that his presentation did not align with typical cases of amnesia or identity disorder they had encountered. He did not appear to be searching for who he was. He appeared certain that he already knew. As of the last update in the case file, Daniel Reeves remains listed as a missing person. The name Michael Turner remains unlinked to any verifiable individual connected to the incident. No explanation was ever formally recorded to account for the discrepancy between identity, memory, and documented evidence. The missing blood samples. On September 3, 2018, staff at Bayou Regional Diagnostics, a private laboratory facility located on the outskirts of Lafayette, Louisiana, reported a discrepancy during a routine inventory check of stored biological samples. The lab specialized in processing blood work for several clinics across southern Louisiana, handling everything from routine panels to specialized diagnostic screenings. According to internal logs, a refrigerated storage unit labeled Unit C4 contained 126 blood samples collected over a 48-hour period. By 8:15 a.m. that morning, 37 of those samples were unaccounted for. The initial discovery was made by lab technician Andrea Boudreau during a standard verification process at the start of her shift. She later stated that the storage trays appeared undisturbed, with no visible signs of tampering, but several labeled vials were simply missing from their assigned slots. Each sample had been logged, barcoded, and scanned into the system upon arrival, with timestamps confirming their placement inside Unit C4 the previous evening, between 6:20 p.m. and 9:05 p.m. The laboratory operated under strict access control protocols. Entry to the storage area required both a key card and a personal identification code, and all movements were recorded through a digital access system. Security footage covered all entry points, including the corridor leading to the refrigeration units. Following the discovery, management initiated an internal review. Access logs showed that between the last confirmed inventory entry at 9:12 p.m. on September 2nd and the next access at 7:58 a.m. on September 3rd, no unauthorized entries had occurred. Only 2 employees had accessed the storage area during that window: night supervisor Calvin Rios at 11:34 p.m. and morning technician Andrea Boudreau at the start of her shift. Both entries were verified by keycard and code, and both individuals appeared on camera entering and exiting alone. Footage reviewed from the corridor showed no irregular activity. No one was seen carrying containers, bags, or any materials that could conceal multiple vials. The refrigeration unit itself was not equipped with an internal camera, but its door sensor recorded each opening and closing event. According to system data, the unit had been opened only twice during the relevant period, corresponding exactly to the two logged entries. Investigators noted that the duration of each opening was consistent with routine checks, lasting less than 2 minutes. The missing samples were traced back to 19 individual patients from 3 different clinics in Lafayette and Baton Rouge. The tests requested included standard metabolic panels, hormone screenings, and 2 cases involving infectious disease markers. All samples had been collected within normal procedures and transported by certified courier to the lab. The courier service provided GPS logs confirming delivery times, and receiving staff signed off on each batch. When contacted, patients were asked to return for new blood draws. Most complied, though several expressed concern about how their medical data had been handled. One patient, identified in reports as Thomas Guidry, declined to return and later filed a formal complaint, stating that he had been waiting on critical results related to a chronic condition. The Louisiana Department of Health was notified within 24 hours, and an external audit was conducted. Investigators examined the lab's digital tracking system, which showed no evidence of deleted or altered records. Each missing sample remained listed in the database as stored, with no subsequent scan indicating removal, disposal, or processing. Barcode scans are required at every stage of handling, and the absence of any such scans suggested that the samples had bypassed standard procedures entirely. Attention then turned to the possibility of internal error. Staff schedules were reviewed, and all employees with access to Unit C4 were interviewed. No one reported unusual activity, and no discrepancies were found in their statements. Calvin Rios, the night supervisor, stated that during his routine check, all samples appeared to be in place. He recalled opening the unit briefly to confirm temperature stability and did not handle any of the vials directly. His account matched the door sensor data and the duration of access recorded. Andrea Boudreau's account of the discovery remained consistent across multiple interviews. She stated that the missing slots were immediately noticeable due to gaps in otherwise sequentially arranged trays. Security personnel also considered the possibility of a system malfunction. However, technical evaluations of the access control system, barcode scanners, and storage unit sensors found no faults. Data logs were intact, with no signs of corruption or unauthorized access. The facility's IT contractor confirmed that any attempt to alter logs would leave detectable traces, none of which were present. As part of the investigation, environmental factors were also examined. The refrigeration unit maintained a constant temperature of 4 degrees Celsius, and there were no recorded fluctuations that could have caused degradation or disposal of samples. Waste disposal logs were reviewed, and no entries corresponded to the missing vials. Biohazard containers were inspected, with no evidence of improperly discarded materials. Despite the lack of physical evidence, the incident raised concerns about the integrity of the lab's procedures. Operations at Bayou Regional Diagnostics were temporarily suspended for 3 days while protocols were reassessed. Additional surveillance measures were implemented, including internal cameras for storage units and redundant logging systems. The missing samples were never recovered. No employee was formally charged or disciplined in connection with the incident. The case remained classified as an unresolved internal discrepancy, with oversight agencies noting the absence of any identifiable breach or procedural failure that could account for the loss. In the months that followed, the lab resumed normal operations. No similar incidents were reported. However, the September 3rd discrepancy remained documented in regulatory filings, with no conclusive explanation. The 37 missing blood samples, each tied to a verified patient and a recorded chain of custody, were never located, and no mechanism was identified to explain how they were removed from a secured system without leaving a trace. The doctor assigned to no department. In January 2016, administrative staff at Greenridge Medical Center in Columbia, Maryland, identified an inconsistency during a routine audit of internal scheduling systems. The hospital, a mid-sized regional facility with over 1,200 employees, maintained a centralized digital roster that tracked physician assignments across all departments, including emergency services, surgery, internal medicine, and outpatient care. During a quarterly review, a name appeared repeatedly across multiple weekly schedules without a corresponding departmental affiliation. The name listed was Dr. Evan Halpern. According to the system, Dr. Halpern had been assigned to rotating shifts over a 6-week period, primarily during overnight hours between December 2015 and mid-January 2016. However, when department heads were asked to verify his role, none reported having supervised or worked directly with a physician by that name. Initial assumptions pointed to a clerical error. Human Resources was contacted to confirm employment records. Payroll data showed that Dr. Evan Halpern had been issued regular payments over the same 6-week period, totaling approximately $18,600. Tax documentation listed him as a contracted physician with a valid Social Security number and a Maryland medical license number attached to his profile. Both identifiers were verified as legitimate through state databases. The license was active and registered under the same name, with a listed address in Silver Spring, Maryland. Attempts to contact the physician using the phone number and email on file were unsuccessful. The phone number was no longer in service, and emails sent to the registered address received no response. Further review of the hospital's credentialing records revealed that Dr. Halpern's onboarding documentation had been approved in late November 2015. The file included standard materials: a copy of his medical license, proof of malpractice insurance, immunization records, and a signed contract authorizing temporary staffing coverage. The signature on the contract was consistent across documents, though no staff member in the credentialing office could recall processing the application. Digital timestamps indicated that the file had been uploaded and approved within a 48-hour window, a shorter time frame than usual for physician onboarding. Attention then shifted to physical presence within the hospital. Security badge logs showed that a badge assigned to Dr. Halpern had been used to access multiple areas of the facility, including physician lounges, medication rooms, and at least 2 inpatient units. The badge was activated on December 2, 2015, and recorded consistent entries during overnight hours, typically between 11 p.m. and 5 a.m. Surveillance footage from key access points was reviewed. In several instances, a man matching the general description from the credentialing file was seen entering restricted areas using the assigned badge. The individual wore standard hospital attire, including scrubs and an ID badge clipped to his chest. However, the footage quality was insufficient to clearly capture facial details, and no close-up images were available. Staff interviews were conducted across departments that had recorded badge activity. Nurses on the night shift in the internal medicine unit recalled seeing an unfamiliar physician during early morning hours, but assumed he was a float or temporary staff member. One nurse, identified as Karen Whitfield, stated that she had briefly interacted with the individual regarding a patient's medication order. She described him as quiet, direct, and familiar with procedures, but could not recall any specific identifying features. No written orders signed by Dr. Halpern were found in patient charts, either electronic or paper-based. Pharmacy records showed no prescriptions issued under his name. Electronic medical record access logs did not list his credentials as having been used to enter or modify patient data. This absence raised further questions, as any attending physician would typically leave a trace within the system through chart entries, orders, or consultations. Despite his presence in schedules and access logs, there was no clinical footprint associated with his activity. Investigators considered the possibility of identity misuse or internal fraud. The Social Security number and medical license both corresponded to a real individual named Evan Halpern, who had completed medical training in Pennsylvania and held an active license in Maryland. When contacted, the individual stated that he had never worked at Greenridge Medical Center and was unaware that his credentials had been used. He confirmed that his license information had been submitted to several staffing agencies in the past but had not accepted any assignments in Maryland during the time frame in question. He also reported no unauthorized access to his personal or professional records. The hospital initiated a formal internal investigation in coordination with local authorities. Digital access systems were examined for vulnerabilities. IT specialists found no evidence of external intrusion or credential compromise. The badge assigned to Dr. Halpern had been issued through standard procedures, requiring in-person verification and photograph capture. However, the photograph stored in the badge system was later found to be corrupted, displaying only a blank placeholder. No backup image was available. Further attempts to trace the onboarding process revealed that the user account responsible for uploading and approving Dr. Halpern's credentials had been deleted. Audit logs showed that the account had administrative privileges and had been active for a limited period before being removed from the system. The identity of the user associated with the account could not be confirmed, as login credentials had been shared among multiple administrative staff during a system transition phase. Financial records confirmed that all payments issued to Dr. Halpern had been deposited into a bank account under his name. Subpoenaed banking information showed that the account had been opened in early December 2015 and closed in February 2016. The funds had been withdrawn in a series of cash transactions from ATMs located across central Maryland. No surveillance footage from those transactions was retained by the banks due to standard data retention policies. By March 2016, the investigation had reached a standstill. No individual matching the identity used within the hospital could be located. No department claimed responsibility for his presence, and no patients were definitively linked to his care. The combination of verified credentials, confirmed physical access, and absence of clinical activity remained unexplained. Greenridge Medical Center updated its credentialing and access control procedures following the incident, implementing stricter verification protocols and individual login requirements. The case was closed internally as an unresolved security anomaly. No criminal charges were filed. The name Dr. Evan Halpern remained in archived schedules and payroll records associated with a period of documented activity that could not be attributed to any confirmed individual within the institution. The room that was never cleaned. On June 11, 2014, a patient identified as Harold Benton, a 67-year-old retired dock worker, was admitted to Palmetto Regional Hospital in Charleston, South Carolina, for complications related to chronic heart failure. According to medical records, Benton was placed in room 428 on the hospital's fourth floor, a general care unit with standard monitoring capabilities. His condition was considered stable upon admission, though he required continuous observation. Over the next 4 days, nursing notes indicated a gradual decline, with increased respiratory distress and limited responsiveness. At 3:12 a.m. on June 15th, Benton was pronounced dead following cardiac arrest. The attending physician, Dr. Melissa Grant, completed the death certificate and standard post-mortem procedures were initiated. The body was transferred to the hospital morgue at approximately 4:05 a.m., and room 428 was logged as vacated in the patient management system at 4:22 a.m. Under normal protocol, the room would be flagged for cleaning and reassignment within a few hours. However, internal housekeeping logs show that room 428 remained marked as occupied in the system for the next 19 days. During that period, no cleaning staff were assigned to the room and no new patients were admitted to it. The discrepancy was first noted by Environmental Services Supervisor Denise Carter on July 4th during a routine audit of room turnover rates. Carter reported that room 428 had not appeared on any cleaning schedule since mid-June, despite being listed as occupied in the system. When she attempted to assign a team to service the room, she stated that she was instructed by a floor coordinator not to proceed. According to her written statement, the coordinator, whose name was later redacted in internal documents, told her that the room was not to be entered and that it was being handled. Carter requested clarification but did not receive a formal explanation. She documented the interaction and escalated the issue to hospital administration. Security access logs for room 428 during the period between June 15th and July 4th show limited activity. The door, which required a staff keycard for entry, was opened on 6 occasions, all during late evening or early morning hours. The entries were not associated with any scheduled cleaning, maintenance, or patient care tasks. The keycards used belonged to 3 different staff members: a charge nurse, a facilities technician, and an administrative supervisor. All 3 individuals were later interviewed. The charge nurse, identified as Rebecca Sloan, stated that she had been asked to check on the room by a supervisor, but found it empty and did not remain inside for more than a few seconds. The facilities technician, Mark Ellison, reported being told to inspect a ventilation issue, but claimed he found no mechanical problems. The administrative supervisor declined to provide a detailed statement, citing lack of recollection. Surveillance footage from the hallway outside room 428 was reviewed as part of the internal investigation. The camera captured each recorded entry, but the angle did not allow visibility into the room itself. In several instances, individuals entering the room remained inside for extended periods, ranging from 10 to 25 minutes. No equipment or cleaning supplies were observed being carried in or out. The door remained closed during these intervals, and no additional staff were seen entering simultaneously. Notably, on June 22nd at 2:47 a.m., footage shows two individuals entering the room together using separate key cards. Their identities were not conclusively confirmed due to partial obstruction of their badges. They exited 18 minutes later without speaking or interacting with other staff in the corridor. When Room 428 was finally accessed by environmental services on July 5th, following direct authorization from hospital administration, the condition of the room was documented in detail. According to the cleaning report, the bed had been stripped of linens, and no personal belongings were present. However, several inconsistencies were noted. The room did not show signs of standard post-discharge cleaning. Dust had accumulated on surfaces, and the bathroom fixtures appeared unused for an extended period. A medical tray remained on a side table containing unopened sterile supplies and a labeled medication cup dated June 14th. The electronic wall monitor was powered off, but its last recorded data entry corresponded to Benton's final hours. No additional entries had been made since. Environmental swabs taken as part of a precautionary protocol did not reveal any biohazard concerns beyond expected levels for an uncleaned room. Maintenance logs showed no reported issues with plumbing, electrical systems, or ventilation during the period in question. The hospital's digital patient tracking system was also reviewed. Despite Benton's discharge status being recorded on June 15th, the room remained flagged as occupied due to an unresolved status code that had not been manually corrected. IT personnel later stated that such errors were rare, but possible during system updates. However, this did not explain the repeated instructions given to staff to avoid entering the room, nor the recorded access by multiple individuals without documented purpose. Interviews with floor staff revealed a pattern of informal communication regarding Room 428. Several nurses reported being told during shift briefings that the room was out of service or under review, though no official notice had been circulated. One nurse, who requested anonymity, stated that she had been advised not to assign patients to that room under any circumstances, even during periods of high occupancy. She also noted that the room's status in the system did not match its physical availability, creating confusion during bed assignments. Hospital administration concluded its internal review in August 2014. The final report classified the incident as a procedural oversight compounded by system error, citing the incorrect occupancy status and lack of clear communication between departments. No disciplinary actions were recorded. The identities of individuals who accessed the room during the restricted period were not formally disclosed, and no explanation was provided for the instructions given to cleaning staff. The case was not referred to external authorities, as no evidence of criminal activity was identified. Room 428 was returned to service on July 7, 2014, and has since been used without reported incident. However, the sequence of events between June 15th and July 5th remains partially undocumented. The reason the room was kept inaccessible, the purpose of the recorded entries, and the origin of the instructions to avoid cleaning it were never clarified in official records. The disconnected call button on the night of November 22, 2019, Street. Augustine Medical Center in Boise, Idaho, operated under standard weekend staffing levels, with reduced personnel across several non-critical departments. The hospital's fourth floor, a mixed-use unit handling post-surgical recovery and general medical cases, housed 23 patients that evening. According to internal records, the nurse-to-patient ratio was within regulatory limits, and no system alerts had been issued prior to the incident. At approximately 2:10 a.m., a patient identified as Margaret Ellis, a 72-year-old recovering from hip replacement surgery, was found attempting to leave her bed unassisted. She had reportedly pressed her call button multiple times over a 20-minute period without response. A nurse conducting routine rounds discovered her standing near the bedside, disoriented but conscious. Ellis later stated in a written report that she had pressed the call button repeatedly but heard no tone, no light, nothing. The nurse assisting her, Daniel Kessler, tested the call button in her room immediately after and reported that it appeared non-functional at that time. Within the next hour, 2 additional patients on the same floor reported similar issues. One of them, Robert Gaines, a 58-year-old admitted for cardiac monitoring, claimed he had pressed the call button after experiencing chest discomfort. According to his statement, there was no audible confirmation or response from staff. His condition stabilized without intervention, but the delay was noted in his chart. Another patient, identified as Laura Kim, recovering from abdominal surgery, reported that her call button did not respond when she attempted to request pain medication. Nursing staff documented these complaints and began informal checks of the call systems in adjacent rooms. At approximately 3:05 a.m., a nurse supervisor initiated a manual test of several call buttons across the unit. The results were inconsistent. In some rooms, the system functioned normally, triggering alerts at the nurse station. In others, including the rooms occupied by Ellis and Gaines, no signal was received. The hospital's call system operated through a centralized digital network, linking bedside buttons to a monitoring panel at the nurse station and to handheld devices carried by staff. Each activation was logged with a timestamp and room number. However, when the logs for the time period between 1:45 a.m. and 3:30 a.m. were later reviewed, no call attempts were recorded from the rooms in question. Maintenance staff were contacted at 3:20 a.m. A technician, Luis Ortega, arrived on the floor at approximately 3:40 a.m. and began inspecting the system. By the time of his arrival, all tested call buttons appeared to be functioning normally. Ortega conducted a full diagnostic check of the network, including signal integrity, wiring connections, and server response logs. His report filed later that morning stated that no faults were detected and that the system had maintained continuous operation throughout the night. No outages, interruptions, or anomalies were recorded in the system's back-end logs. Despite this, nursing staff continued to report that several patients had experienced unresponsive call buttons during the same time frame. The hospital initiated an internal review on November 23rd. Interviews were conducted with all staff assigned to the fourth floor during the night shift. None reported hearing or seeing alerts from the affected rooms during the period in question. The nurse station logs, which display real-time alerts, showed no missed or delayed notifications. Handheld devices issued to staff also showed no incoming signals from those rooms. Patients' accounts were documented and compared against system data. All three primary complaints occurred within a 90-minute window. None of the call attempts described by patients appeared in the digital logs. Investigators considered the possibility of user error, including improper use of the call button or confusion due to medication. However, all three patients were assessed as cognitively stable at the time, with no documented impairments that would affect their ability to operate the system. Additionally, the consistency in their descriptions raised questions about whether the issue was isolated or systemic. Further review identified 2 additional patients who had not formally reported issues but later confirmed that they had experienced delayed or absent responses after attempting to use their call buttons. These accounts were collected during follow-up interviews conducted days after the incident. Neither of these patients had their call attempts logged in the system during the relevant time frame. Technical consultants were brought in to evaluate the possibility of a transient network failure that might not have been captured in standard logs. Their analysis concluded that while brief signal interruptions could occur, they would typically generate error entries or trigger fallback protocols. No such indicators were found. The system's redundancy features, designed to reroute signals in case of failure, showed no activation during the period in question. Security footage from the nurse station and hallway was also reviewed. The footage confirmed that no staff responded to calls from the affected rooms during the time frame described. It also showed that staff activity levels remained consistent, with no indication of distraction or system overload. No alarms or visual indicators were observed on the nurse station monitors during that time. The incident raised concerns about patient safety and system reliability. However, without physical evidence of malfunction or digital records supporting the reported failures, the hospital faced limitations in identifying a cause. The final internal report, issued in January 2020, categorized the GTNA as an unverified system discrepancy with no identifiable technical fault. Recommendations included additional staff training, increased frequency of manual checks during night shifts, and consideration of system upgrades. No disciplinary actions were taken. The patients involved were discharged without further complications. No similar incidents were officially reported in the months that followed. The events of November 22nd remain documented in internal records, marked by a gap between patient experience and system data that was never reconciled. The unidentified surgical team member, on April 17, 2017, A scheduled laparoscopic appendectomy was performed at North Valley Medical Center in Fort Wayne, Indiana. The patient, identified as 29-year-old Emily Carter, had been admitted earlier that day with acute abdominal pain consistent with appendicitis. Preoperative evaluations were routine, and the procedure was classified as low risk. The surgical team assigned to operating room 3 included lead surgeon Dr. Anthony Keller, anesthesiologist Dr. Priya Nandakumar, and 2 registered nurses, Melissa Grant and Jordan Pike. The operation began at 6:42 p.m. and concluded without reported complications at 7:58 p.m. Initial post-operative assessments indicated a standard recovery trajectory. However, within 48 hours, a discrepancy emerged during a routine chart audit conducted by the hospital's Surgical Oversight Committee. The audit, part of a monthly quality assurance process, reviewed video recordings from select procedures, including Carter's surgery, which had been recorded for internal training purposes. Upon reviewing the footage, auditors noted the presence of a 5th individual in the operating room who was not listed in the official surgical record. The individual appeared throughout the procedure, positioned opposite Dr. Keller, assisting with instrument handling and suction control. The person wore standard surgical attire, including a mask, cap, and sterile gown, with no visible name tag or identifying marker. The footage showed the individual entering the operating room shortly after anesthesia was administered and participating actively in the procedure. The individual's movements were consistent with those of a trained surgical assistant, responding to cues and maintaining sterile protocol. However, when cross-referenced with the surgical log, no such assistant was listed. The official record documented only 4 personnel present. Hospital protocol required that all individuals in the operating room be logged prior to incision, with their roles clearly defined. The absence of this individual from the record prompted an internal investigation. Interviews were conducted with all listed members of the surgical team. Dr. Keller acknowledged that an assistant had been present, but stated that he assumed the individual was a floating surgical technician assigned by the hospital's staffing pool. He could not recall the person's name or when they had entered the room. Nurse Melissa Grant reported a similar assumption, stating that the individual appeared to belong and followed standard procedures. She noted that in high-volume periods, additional support staff were occasionally assigned without prior notice. However, no such assignment was documented for that shift. Anesthesiologist Dr. Nandakumar stated that her focus remained on the patient's vitals and that she did not take note of additional personnel unless directly involved in anesthesia management. The hospital's staffing records for April 17th were reviewed in detail. No surgical assistant or technician matching the description was scheduled for operating room 3 during the relevant timeframe. Badge access logs for the surgical suite were also examined. Entry to the operating area required a proximity badge, with each entry and exit time recorded. The logs showed 4 authorized entries corresponding to the listed team members. No additional badge activity was recorded for that room. Between 6 p.m. and 8:30 p.m., surveillance footage from the hallway outside operating room 3 was reviewed. The camera captured all personnel entering and exiting the room. At 6:39 p.m., 3 individuals were seen entering together, followed by a 4th at 6:41 p.m. No 5th individual was observed entering through the main door. The footage showed no anomalies, no tailgating, and no unauthorized access. The possibility of entry through a secondary access point was considered, but the operating room had only 1 functional entrance, and all other access points were sealed or alarmed. The internal layout of the surgical suite was also reviewed. No alternative entry routes existed that would allow undetected access to operating room 3. The video recording itself was verified for authenticity. Metadata confirmed that the footage had not been altered or edited. Timestamps aligned with the surgical log, and the presence of the unidentified individual was consistent across multiple camera angles within the room. The individual's face was obscured by standard surgical coverings, and no distinguishing features were visible. Voice analysis was inconclusive as the individual did not speak audibly during the recorded segments. Further examination of the footage revealed that the individual handled instruments, adjusted lighting, and assisted in tissue retraction, all actions requiring familiarity with surgical procedures. At one point, Dr. Keller handed a laparoscopic tool directly to the individual without verbal instruction, suggesting a level of coordination typically developed through prior collaboration. Despite this, Dr. Keller maintained that he had no recollection of working with that specific person before or after the procedure. The patient, Emily Carter, was interviewed as part of the review. She reported no irregularities in her care and recovered without complication. No additional procedures were performed, and no foreign objects were found during post-operative imaging. The surgical outcome did not indicate any deviation from expected standards. The investigation expanded to include a review of recent hires, temporary staff, and external contractors. No records matched the profile of the individual seen in the footage. Nearby hospitals were contacted to determine if any staff had been cross-assigned or mistakenly scheduled at North Valley Medical Center. No such arrangements were identified. The hospital's credentialing system showed no recent entries or temporary access grants that would correspond to the unidentified individual. In June 2017, the hospital concluded its internal investigation. The final report acknowledged the presence of an unidentified individual in the operating room during a recorded procedure, but stated that no explanation could be determined regarding their identity or method of access. The report emphasized that no breach of patient safety had been identified and that all surgical outcomes remained within acceptable parameters. Recommendations included stricter enforcement of personnel logging procedures and the implementation of additional verification steps prior to surgical entry. No disciplinary actions were taken against the surgical team. The case was not referred to law enforcement as no evidence of criminal intent or harm was established. The footage of the procedure was archived and access was restricted. The identity of the individual remains unknown. No similar incidents have been officially reported at the facility since that date. The presence of a fifth team member actively participating in a controlled surgical environment without record or recognition remains documented in hospital records without resolution. The chart with no author. In early February 2015, administrative staff at Redstone Medical Center in Tulsa, Oklahoma, identified an irregularity during a routine audit of patient documentation within the hospital's hybrid record system, which combined electronic files with handwritten physician notes. The case centered on a patient named Charles Weller, a 54-year-old admitted on January 28th for complications related to uncontrolled diabetes and a suspected foot infection. His condition required close monitoring, including daily evaluations by attending physicians, wound care specialists, and nursing staff. According to the official electronic record, Weller's treatment followed a standard progression, with antibiotics administered and surgical consultation scheduled. However, during a file review conducted on February 3rd, a set of handwritten notes was discovered inserted between printed chart pages containing detailed observations and treatment recommendations that were not reflected in the electronic system. The notes were written in clear, structured handwriting and included specific medical terminology, dosage adjustments, and references to lab values that had not yet been entered into the system at the time the notes were dated. The entries were signed only with initials that did not correspond to any provider assigned to Weller's care. The first note was dated January 30th at 6:15 a.m., a time when no physician rounds had been scheduled. It described a subtle change in the patient's vascular response and recommended a modification in antibiotic therapy. The second note, dated January 31st, referenced lab result that, according to system logs, had not been processed until later that afternoon. The third entry, dated February 1st, suggested a surgical intervention that was formally ordered by the attending physician nearly 18 hours later. Nursing staff confirmed that the recommendations outlined in the notes had, in fact, been followed, though they could not identify who had issued them. Several nurses stated that they had seen the notes during their shifts and assumed they had been written by a consulting specialist or a physician covering an early round. When questioned, all attending physicians assigned to Weller's case denied authorship of the notes. Dr. Stephen Mallory, the primary attending, stated that while the recommendations aligned with his eventual decisions, he had not documented them in that form or at those times. He also noted that the handwriting did not match his own or that of any colleague he recognized. The hospital initiated an internal review beginning with a handwriting comparison across all medical staff. Samples were collected from physicians, residents, and nurse practitioners who had access to the unit. A forensic document examiner was consulted to analyze the writing style, letter formation, and pressure patterns. The examiner concluded that the handwriting did not match any of the submitted samples and appeared consistent across all three entries, indicating a single author. The possibility of unauthorized access to the patient's chart was considered. At the time, physical charts were stored in a central station on each floor, accessible to all authorized staff. There were no surveillance cameras directly monitoring the chart station, and access was not individually logged. However, staff presence on the unit was tracked through badge swipes and shift schedules. Review of these logs showed no unaccounted individuals during the relevant timeframes. All staff on duty were identified and interviewed. None reported seeing anyone unfamiliar handling the chart. Further analysis focused on the content of the notes. The level of detail suggested a high degree of clinical expertise, particularly in vascular complications and infectious disease management. The terminology used was precise and the recommendations were consistent with best practices. However, the timing of the entries raised questions. The January 31st note referenced a white blood cell count that had not been entered into the system until 2:40 p.m., yet the note was time-stamped at 8:10 a.m. Laboratory staff confirmed that the sample had been collected earlier that morning, but had not been processed until later due to equipment delays. There was no documented way for a provider to access those results at the time the note was written. The surgical recommendation on February 1st also drew attention. The note described early signs of tissue necrosis not yet documented in the official record. Dr. Mallory later confirmed that he had observed those signs during his afternoon evaluation and subsequently ordered a debridement procedure. When asked whether anyone else could have identified the issue earlier, he stated that it was possible but unlikely without direct examination. No record existed of any additional provider assessing the patient during that window. The physical chart was examined for signs of tampering. The notes were written on standard hospital paper, consistent with materials used throughout the facility. Ink analysis did not reveal any anomalies, and the pages showed no signs of insertion or removal. The notes were integrated into the chart in chronological order, as if placed there at the time of writing. No fingerprints of evidentiary value were recovered from the pages. The investigation extended to recent staff departures and visiting specialists. Records showed no temporary staff or consultants assigned to the unit during the relevant dates. Nearby hospitals were contacted to determine if any personnel had been mistakenly assigned or had accessed Redstone's facilities without proper documentation. No such cases were identified. Charles Weller underwent the recommended surgical procedure on February 2nd and recovered without major complications. He was discharged on February 10th. When interviewed, he stated that he recalled being examined by multiple individuals, but could not distinguish between them or identify anyone outside the normal care team. He did not recall any specific interaction that would correspond to the undocumented notes. In March 2015, Redstone Medical Center concluded its internal review. The final report acknowledged the presence of detailed, unsigned handwritten notes in a patient chart that could not be attributed to any known provider. The report stated that while the recommendations in the notes were medically appropriate and may have contributed to the patient's outcome, the lack of authorship and documentation raised concerns about record integrity and accountability. No disciplinary actions were taken, and no external investigation was initiated. The chart was archived with the notes included, marked as an unresolved documentation anomaly. The identity of the individual who authored the entries was never established, and no explanation was provided for how the information contained in the notes was obtained or recorded ahead of official system updates. The security footage loop on August 9, 2021, Valley Crest Medical Pavilion in Sacramento, California, initiated an internal review following an incident involving a patient in its post-operative recovery wing. The patient, identified as 46-year-old Daniel Hargrove, had undergone a routine spinal procedure earlier that afternoon. According to surgical records, the operation concluded without complications, and Hargrove was transferred to the third-floor recovery unit at approximately 6:10 p.m. He was placed under standard observation, with periodic monitoring scheduled every 30 minutes. At 8:32 p.m., a nurse entered his room and documented that he was awake, responsive, and in stable condition. At 9:05 p.m., during the next scheduled check, the room was found empty. The bed showed signs of recent use, but no personal belongings were missing. Hargrove's hospital gown was left folded on a chair, and his IV line had been disconnected without triggering any alarm. The immediate response involved a floor-wide search and a review of security protocols. The recovery unit was equipped with controlled access points and continuous video surveillance covering all corridors, exits, and nurse stations. Initial assumptions were that Hargrove had left the room unassisted and moved through the hallway. However, when security personnel began reviewing footage from the third-floor corridor outside his room, an anomaly was identified. The video segment covering the time between 8:40 p.m. and 9 p.m. appeared to repeat itself in a continuous loop. The footage showed a nurse pushing a supply cart past room 312 at 8:41 p.m., followed by a brief period of inactivity, and then the same sequence repeated identically, including movements, lighting, and timestamps. This loop persisted for exactly 20 minutes of recorded time. Beyond that window, the footage resumed normal progression. IT staff were called to examine the system. The hospital's surveillance infrastructure operated on a network of synchronized digital cameras, each feeding into a central server with redundant storage and time-stamped recording. According to system logs, camera 3B, which covered the corridor outside Hargrove's room, had recorded continuously without interruption. No errors, dropped frames, or overwrites were detected. The file corresponding to the 8:40 to 9 p.m. interval was intact, with no indication of duplication or manual editing. Metadata analysis confirmed that the timestamps embedded in the footage matched the system clock, and no discrepancies were found in synchronization across other cameras. Investigators expanded their review to adjacent cameras, covering nearby hallways and stairwells. Footage from camera 3A, located at the opposite end of the corridor, showed normal activity during the same time period, including staff movement and patient transport. However, the section of the hallway directly outside room 312 was not visible from that angle. No footage from any other camera captured Hargrove exiting his room or entering another area. Access control logs for the unit's exits showed no badge activity corresponding to his departure. Doors equipped with alarmed exits did not register any unauthorized openings. Interviews with staff on duty that evening revealed no direct observations of Hargrove leaving his room. The nurse who had last checked on him, identified as Laura Mendez, stated that he appeared alert but physically limited due to the recent procedure. She noted that he would have required assistance to walk unaided. No requests for help had been logged through the call system, and no alarms had been triggered from his bed or IV equipment. Maintenance records confirmed that all monitoring systems were functioning normally before and after the incident. The repeated footage raised questions about whether a segment had been overwritten or duplicated due to a technical fault. However, forensic analysis conducted by an external digital security firm found no evidence of system malfunction. The video file showed a continuous data stream with no breaks or insertions. Frame-by-frame comparison confirmed that the repeated segment was identical down to pixel-level detail, including subtle variations in lighting and shadow, suggesting that it was not a simple replay but a duplication embedded within the original recording. The origin of this duplication could not be determined. Further investigation into the hospital's network activity during the relevant timeframe revealed no unauthorized access or data transfers. Firewall logs showed no external connections to the surveillance system, and internal user activity did not include any commands that would affect video recording or storage. The system's redundancy protocols designed to prevent data loss had not been activated, indicating that no failure had occurred that would require backup substitution. As part of the review, investigators attempted to reconstruct Hargrove's movements using all available data. His electronic medical record showed no entries after 8:32 p.m. His wristband, equipped with a passive tracking chip used for internal location monitoring, did not register any movement outside room 312. The system last recorded his presence in the room at 8:33 p.m., with no subsequent updates. The tracking system relied on proximity sensors placed throughout the unit, and while it was not designed for real-time tracking, it typically registered transitions between zones. No such transitions were recorded. Search efforts extended beyond the recovery unit to include stairwells, elevators, and exterior areas of the hospital. No trace of Hargrove was found. Local authorities were notified, and a missing person report was filed. The case was reviewed by Sacramento police, who examined the surveillance footage and system logs. Their report noted the anomaly in camera 3B but did not identify any criminal activity or external involvement. The absence of physical evidence combined with the lack of system errors limited the scope of the investigation. In the weeks following the incident, Valley Crest Medical Pavilion implemented additional monitoring measures, including secondary camera angles and enhanced logging protocols. No similar gate no were reported. The footage from camera 3B remains archived, with the 20-minute loop preserved as originally recorded. Daniel Hargrove was never located, and no explanation was provided for the gap in visual record during the time he is believed to have left his room. Thank you for staying until the end, where each unanswered detail lingers in quiet spaces, reminding us that time does not erase what is hidden, and that some truths remain suspended in silence just beyond reach.